I just have to say I'm extremely impressed with the democracy in Athens. I understand that this is the birthplace of democracy, but when it comes to having to take a vote on air conditioning versus no air conditioning, I think that's really impressive. Okay, so could I have your attention, please? Okay. I'd like to just announce again and remind you that all of the speakers have actually updated, we have updated our talks throughout the sessions here. And so what you see on the previous web page may not be exactly the same as what you will be seeing a little bit later, because we have done a lot of updating on the lectures. So what you will be getting at the end of the day will be the most updated lectures with everything that we have in our lectures over the last 3 days. Okay. So again, the username is what? Athens. Okay. And password is? IPOKRaTES. Okay. Very good. Okay. So let me start with a story on necrotizing enterocolitis. Several years ago, I was in Milan, Italy, and I was giving a lecture on necrotizing enterocolitis. And at the end of the lecture, this very well-known pediatrician from Sweden asked me, "You people in the United States, there's something wrong with you. You have so much necrotizing enterocolitis. And we in Sweden, we just don't see necrotizing enterocolitis. What's wrong with you? What do you do differently than what we do in Sweden?" And so I was just taken aback. I didn't know how to answer this very well-known person. And so I said, well, in the United States, we have a very heterogeneous population, different socioeconomic status. We don't use as much breast milk as you use in Sweden. And, so I was just taken aback by, I didn't really know how to answer him. But a couple months later, I was at another meeting in Latvia. And there was a neonatologist from Karolinska, also in Sweden, and he was complaining to me that they had 6 cases of necrotizing enterocolitis in their unit at that time. So I think the point is that necrotizing enterocolitis is one of these diseases that you may feel like you're doing great in your unit, but things may change, slight things may change, and this happens in a lot of places where all of a sudden you start seeing more necrotizing enterocolitis. And probably one of the major causes for an increase in necrotizing enterocolitis is trying to save smaller babies. If you really get very aggressive with trying to save the smallest babies, you start seeing more of the classic form of necrotizing enterocolitis. So let me go on here with, continue with some of the things that Cami was talking about. I'm actually going to focus on biomarkers for necrotizing enterocolitis, but I'd like to give you a little bit more background and then talk about the microbial ecology of babies who develop necrotizing enterocolitis. This is a relatively new field that our group at the University of Florida is involved in, and also in the development of predictive or diagnostic biomarkers for necrotizing enterocolitis. So the question is, we already have some things that we call biomarkers for diagnosing this disease, and I'll talk about these, but these are really based on the history, physical examination, radiographic criteria, and these detect the disease after its occurrence, usually when it's already too late. The diagnostic biomarkers would help us detect the disease very early in its pathogenesis, and predictive biomarkers would be biomarkers that we could use very early on to predict which babies would be at the highest risk for the development of the disease so that we can intervene with various kinds of strategies to try to focus on those babies that are at the highest risk rather than treat the entire population with something that could potentially cause harm in the babies who it would not help. So when we talk about necrotizing enterocolitis, I think that Cami really remarked on this, but one of the things that I hear so often, and just heard it earlier today, Ariadne said that they had many cases of necrotizing enterocolitis. And sometimes I think that you have to try to decide on what is truly considered to be necrotizing enterocolitis and what is not necrotizing enterocolitis. And there are so many different disease entities that we are beginning to lump into this thing called necrotizing enterocolitis that if we try to develop some kind of therapy for it or prevention for it, I think we have to aim at a certain specific pathway. For example, if we have the classic form of necrotizing enterocolitis, which I'll talk about, we have to aim at for a specific pathophysiologic pathway for that particular disease. That is different than some of the diseases that we see in term infants, for example, as Cami talked about. So, again, in term infants, we will see necrosis of the bowel, and I'm calling this necrosis of the bowel. And it's usually an ischemic necrosis of the bowel in babies who have congenital heart disease. So one of the major heart diseases that will cause ischemia of the bowel is hypoplastic left ventricle, okay? And that is a very different pathophysiologic pathway than the pathway that we think causes the classic form of necrotizing enterocolitis. Okay, so what do we have on these two x-rays? This is a baby's x-ray right after birth, and this is 12 hours later. What are we seeing? Okay, we are seeing air in the peritoneal cavity. And that air in the peritoneal cavity was caused by a little perforation in the ileum. But there is no necrosis of this bowel. This is what is called isolated intestinal perforation. Is this real necrotizing enterocolitis? Well, probably not. Probably not. I think that there's some room for argument here that it's along the same spectrum, but these usually occur very early. These are not related to feedings. Many of these babies get these isolated perforations before they're even fed or when they're only getting a tiny amount of enteral feeding. They are highly related to the combined use of early dexamethasone or hydrocortisone and indomethacin. Okay? A couple of the studies that have looked at this show up to 20% incidence of isolated intestinal perforation when you use that combination of drugs in preterm babies. Very dangerous combination. Here we have the classic form of necrotizing enterocolitis, and you've already seen this. This is what the baby looks like classically, distended abdomen, maybe a little bit of erythema. Here we have pneumatosis intestinalis, portal venous gas, and this is necrosis at the time of surgery. The staging that we have for necrotizing enterocolitis was developed in the late 1970s. And I think that we have to get away from this staging. It's very unhelpful from the standpoint that stage 1 is so often included or attempted to be included in data sets or in papers that people publish for necrotizing enterocolitis. They will call something necrotizing enterocolitis that is something that we see in so many of our preterm babies. Nonspecific radiologic signs such as temperature instability, apnea bradycardia, lethargy, mild abdominal distension. Okay? There's no necrosis of the bowel in these babies. And so I think that that's a misnomer. We need to get away from calling this necrotizing enterocolitis. We can say that the baby is having signs of instability, or there's some problems with the baby's gastrointestinal tract that are nonspecific, but to call it necrotizing enterocolitis, I think, is a mistake. Stage 2, here we have something that you can actually say, you can prove that there is a disease. You have pneumatosis intestinalis, or portal venous gas. Stage 3 usually progresses on to a perforation, or the baby getting so sick with decreased platelet count, increased acidosis, decreased leukocyte count, where the baby is showing signs of a necrotic bowel. Okay, so you can call this medical necrotizing enterocolitis, and you can call this surgical necrotizing enterocolitis without even invoking the name stage. Okay, and Cammie brought this up before, and this is actually something that we did many years ago. I asked one of our fellows back in the late 1980s to take 3 years of our necrotizing enterocolitis experience at the University of Florida, and to plot these 3 years in terms of gestational age and average onset of necrotizing enterocolitis. Okay, so this is age in weeks, and this is gestational age. We have very few babies who actually develop necrotizing enterocolitis greater than 32 weeks gestation. But here we go, as you go down and you decrease the gestational age, we see that in the very preterm babies, these are babies 24, 25 weeks gestation, we see the disease developing quite late, okay? And in the babies that are more mature, we see it developing quite early, okay? Usually within the first 2 weeks in the more mature babies. And this has actually been done in several other studies. Cammie showed you one of them. This is another one of the studies that seem to show a peak in post-conceptional age in the development of necrotizing enterocolitis. There's something special that seems to happen between 29 weeks gestation and around 34 weeks gestation, where post-conceptional age, where you start seeing this disease. We don't know what that is, whether it's due to some vascular phenomena, whether it's due to seeding early on with some specific microbes, as Cammie mentioned, we don't know. But that's a very, very interesting finding. Now, what about the microbes in the gastrointestinal tract? We've been suspicious of a microbial etiology of necrotizing enterocolitis for a long time. NEC is usually not seen in the fetus. It seems that colonization of the intestine seems to be a prerequisite. We do see that critically ill low birth weight neonates do not develop a normal gut flora, and that most are exposed to antibiotics and the NICU microflora. That's a different microflora than those babies would have if those babies would be at home. And NEC does seem to occur in clusters, which also suggests a microbial origin. Well, over the years, using culture-based techniques, bacterial culture-based techniques, a lot of studies have looked at stool cultures, at blood cultures, et cetera, of babies with necrotizing enterocolitis, and have not been able to find a specific microbe associated with necrotizing enterocolitis. About 15 years ago, there was a very interesting paper that came out in Science that showed a high association of coronavirus with necrotizing enterocolitis. People tried to repeat that study, have never been able to repeat that study that was reported in this very prestigious journal, Science, 15 years ago. But we do think that there's a microbial origin. And now we have some techniques that are not based on culture, but are based on microbial DNA. And we are able to now detect a lot more microbes, microbial types in our gastrointestinal tract than we were ever able to detect before, okay? It's thought that we are only able to culture about 30% of the microbes in our gastrointestinal tract. And with these new technologies, we should be able to do much better. Now let's get back to the kinds of microbes that we have in the gastrointestinal tract. When you look at the aboral gradient of microbes in the gastrointestinal tract, from the top of the gastrointestinal tract to the bottom, we have very few microbes in our upper gastrointestinal tract. You may see some Helicobacter pylori, which are important for certain reasons. And as you start going down further into the ileum, you start to see 10 to the 7th, 10 to the 8th microbes per milliliter of gastric contents. Then you get into the large intestine, you will see 10 to the 11th to 10 to the 12th microbes per milliliter. So huge numbers of microbes in our gastrointestinal tract. In fact, there are at least 10 times as many microbial cells in our gastrointestinal tract as cells that are present in our entire body. And there are approximately 100 times as many genes, microbial genes, in our gastrointestinal tract as there are genes in our entire body. So it's a little bit humbling to think that we are only about 10% human. When you think about some of the roles that these microbes play, you can actually split some of the major roles into two categories. One category is a bioreactor role, and the other is an immunologic role. The bioreactor role has a lot to do with nutrient metabolism. Okay? For example, these microbes will cause help the production of vitamin K, choline, various factors that are very important for our nutrition. They produce short-chain fatty acids in their fermentative processes, which are also very important for various metabolic functions. The other major role is the immunologic role, and I'll talk a little bit about that shortly. But you see importance for tissue development, resistance to colonization with pathogens, and maintenance of intestinal homeostasis. How do bacteria prevent damage to the gastrointestinal tract? Well, I think Cammie touched on this with several different mechanisms, and I'd like to just talk a little bit more about this, the toll-like receptor area. And the story behind toll is very, very interesting. Toll is a protein that was discovered about a little bit over 30 years ago, and the story that I've been told from very reliable source is that at the University of Tübingen in Germany is where the toll proteins were first discovered. And what happened was that they were looking at Drosophila, the fruit fly, and how the fruit fly differentiates into anterior, posterior, ventral, how the fruit fly differentiates into its head and into its tail. And a graduate student saw some of these very interesting proteins on a gel and took these proteins on the gel to her professor, and the professor looked at it and said, "Das ist toll." This is really cool. In German, toll means really cool, okay? And so these proteins were called toll. And not until around 20 years ago at Yale University, when Dr. Janeway and colleagues started looking at macrophages and the innate immune system in macrophages, where they started to realize that there were some receptors present on various immune cells, such as macrophages, that looked like these toll proteins that were found previously. And they found that these toll receptors were almost exactly the same as the toll proteins that were found in Drosophila. And they found that these were receptors that were very important for binding to various microbial components. And now we know that there are approximately 12 of these toll-like receptors, and here's some of them on this slide. Some very important ones here. Toll-like receptor 4, that was already referred to. Toll-like receptor 4 binds to LPS, which is found on the cell wall of gram-negative microorganisms. Toll-like receptor 2 binds to lipoproteins found largely on the cell wall of gram-positive microorganisms. Toll-like receptor 5 binds to flagellin, very important in Salmonella. Toll-like receptor 9 binds to microbial DNA. Okay, these are all very important receptors that act through these signaling pathways through NF-kappa beta, which is a transcription factor. And Cami mentioned some of these mechanisms, but what I'd like to do is take you through an experiment that was done at Yale University that I think is very important in regard to our understanding of microbes in the gastrointestinal tract and toll-like receptors, and is actually very important to some of the things that we do in the neonatal intensive care unit. So let me start with this experiment. What they did was they had 4 groups of mice, regular wild-type mice. Then they had a knockout mouse, which knocked out this MYD88, which is a signaling adapter molecule. Then they had mice that had knockouts of TLR4 and TLR2. Okay, so 4 groups of mice. They took these 4 groups of mice and subjected them to various conditions, 3 major experiments. One was an experiment where they took these mice and they subjected them to this oral dextran sodium sulfate, which is a mild detergent that causes very mild intestinal injury in healthy animals. Okay, that was one experiment. Then they took the wild-type mice and depleted them of all of their intestinal bacteria by using antibiotic treatment. And then they took these mice that were depleted of their bacteria, their intestinal bacteria, and actually pre-treated them with some of these components of the cell wall, LPS and lipoteichoic acid, before they depleted them of their microbiota. So let's get into these experiments. The toll-like receptor knockouts that were exposed to the dextran sodium sulfate. Here we have the 4 different groups, wild type up here. Here's the 3 different knockout mice. Here's survival. The knockout mice did not survive this. They all had developed hemorrhagic colitis, started bleeding into their colon, and ended up dying. But the wild type mice did fine. So this is telling us that those 2 receptors and the signaling molecule is important. Okay, so that's point number 1. Now I'm going to digress just a little bit and show you this picture. This is a person diving into a pool, and there's no water in that pool. Okay? This is a neonatologist. And this neonatologist is diving into this pool without any water in it. The question is, could peripartum antibiotics or probiotics have unforeseen or delayed health consequences? Well, let's talk mainly here, the antibiotics. Okay? This is the second part of their experiment. They tried to determine whether intestinal microbes were important for protection in the gastrointestinal tract. So they had 4 groups. One was no antibiotics plus DSS. Another group, they gave 4 different antibiotics: ampicillin, vancomycin, neomycin, metronidazole plus the DSS. Another group received neomycin and metronidazole plus DSS. Another group, vancomycin and metronidazole plus DSS. This group here, with the 4 different antibiotics, did very poorly, died of hemorrhagic colitis. The other groups did okay. So some antibiotics, not that bad, but a lot of antibiotics, bad. Then the third part of their experiment, they took LPS and lipoteichoic acid. These are actually components of microbes that you would think would cause inflammation. But they gave these 2 components first before depleting the animals of their intestinal microbes. Just like in the previous experiment, they depleted them of the microbes. So here we have DSS alone, that's the control group. Here we have the conventionally depleted group. This is the group that did very poorly in the previous experiment and did very poorly here. But here's the group that received LPS, or lipoteichoic acid, first. They did fine. So giving these animals some of this lipoteichoic acid, or LPS, actually prevented the damage to the gastrointestinal tract. So there's something about these particular agonists of toll-like receptors that can actually prevent damage to the gastrointestinal tract. Here's a slide that you've seen before, and this summarizes that paper. This was from the New England Journal. The other paper was from Cell and was written in 2004. And here is the normal situation where you have TLR ligands or microbes present in the gastrointestinal tract. Here you have intact toll-like receptor signaling pathways. And here you have homeostasis of the intestinal surface. The gut is healthy. Here, if these are not working well, the toll-like receptors are not working well, and if you do have microbes in the gastrointestinal tract, you have enhanced sensitivity to injury, diminished capacity to induce repair. And here, if you have no toll-like receptor signaling, in other words, you have a lack of microbes in the gastrointestinal tract, enhanced sensitivity to injury, diminished capacity to repair. Okay, so let's get into the neonatal intensive care unit. What do we do to our neonates, our very low birth weight babies? This is work that was done by Reese Clark and colleagues looking at a very large cohort of babies. The most commonly used medications in the neonatal intensive care unit are seen on this slide, the top 10. And what are the top 2? Ampicillin and gentamicin. Okay? Probably about 90% of the babies in most of our neonatal intensive care units receive at least a little bit of ampicillin and gentamicin. Right? Okay, most people are saying, yeah. Okay. So we know why that's done, and it's very interesting that when we draw the blood cultures in these babies, do you know what percentage of those blood cultures are actually positive? How many? 60%? 20%? 4%? Any others? 1 to 2%. 1 to 2% of the blood cultures on early onset, when you look at the, when you take the blood cultures right after birth from our preterm babies, right after birth, right after birth, not later, but right after birth from our preterm babies that get these antibiotics, only 1 to 2% are positive, okay? Before taking the antibiotics, yes, okay? So let's think a little bit more about what these antibiotics do to the gastrointestinal tract. Here is some work that came from Switzerland in physiologic genomics in 2005. And what they did was they looked at baby rats. And in these baby rats, they had 2 groups. One group received Clomoxyl at 100 milligrams per kilo per day for 7 days. The other group did not receive any antibiotic at all. Then after 7 days, they sacrificed these animals, and they looked at the cultures in the colon. They found that all bacteria were significantly reduced, especially lactobacillus. And then they took the intestine and they looked at what's called an Affymetrix gene microarray. They looked at the RNAs that were being produced by the intestine. And they found that 10 to 30% of the genes that were undergoing maturational changes showed modulation, either up or down regulation by the antibiotic. Then they also looked at the MHC locus, the MHC genes. These are the major histocompatibility genes that are very important in tolerization. Many of those were also markedly affected. So antibiotics have a major effect on the development of the gene production in the gastrointestinal tract, including that part of the gastrointestinal tract that is involved in tolerization to antigens. Necrotizing enterocolitis and antibiotics. Cami brought this up before. This is a very recent study, just came out last month in pediatrics. Days on antibiotics, odds ratio for necrotizing enterocolitis. So the longer the time the baby is on antibiotics, the greater the odds ratio. Now, is that because the babies are sicker, that they get more antibiotics, and that they then develop more necrotizing enterocolitis? I don't think that that's yet 100% clear, but I think that this relationship has now been seen in several other studies. And I think that it's enough to make us concerned that these antibiotics that we are giving to our preterm babies, we need to start looking very closely at that. Now, at the University of Florida, we started to do a study looking at the microbial ecology of the gastrointestinal tract. We started this study a little bit over 3 years ago, and we were able to get some funding from the National Institutes of Health to do this. And what we're doing is collecting stool samples from babies from 3 different hospitals. And one hospital is in Gainesville, Florida. 2 hospitals are in Jacksonville, Florida. And we now have 2 freezers full of baby poop. We have 650 babies so far enrolled in this study. But these are babies less than 1,250 grams, less than 32 weeks gestation. And we are also doing some other collections of samples, such as buccal swab samples, and I'll show you that later. And what we are doing is when babies develop necrotizing enterocolitis, we find control babies to those babies who develop necrotizing enterocolitis and match them on various factors, as you see here. Okay? Well, we did a pilot study to look at this, and this is now published in the PLOS journal. It was published last May. And we had 9 babies in the necrotizing enterocolitis group and 9 babies in the control group. And here you can see some of the characteristics. It's just kind of interesting that the diet here, if you look at the diet here, this is formula, this is both formula and breast milk, this is formula, both breast milk and formula, and then here's the controls, breast milk, breast milk, breast milk, both breast milk, breast milk, breast milk, breast milk, both. Okay, a little bit more formula. Way too few babies to make an analysis, but it seems to be trending that as we would guess, that the group that received that developed necrotizing enterocolitis had more formula. The other interesting point here, and each one of these letters stands for antibiotics, different antibiotics used. We have more letters over here in the cases compared to the controls. Very similar to what I was just telling you before. Now, looking at the microbial ecology of the gastrointestinal tract using non-culture-based techniques involves looking at sequencing techniques, and you can sequence these microbes to various depths. And the sequencing can go from a phylum level, and remember the Linnaeus classification of taxonomy. You go from kingdom, phylum, class, genus, order, family, species. Okay, you can do the same thing using this non-culture-based technology, where you can go in depth further and further. Well, this slide just shows the microbes at a phylum level using the non-culture-based technology. And what we are seeing is that there are 4 major phyla in the gastrointestinal tracts of these babies, 4 major phyla. These are the names of the phyla: Actinobacter, Bacteroidetes, Firmicutes, and Proteobacteria. And each one of these colors stands for a different phylum. These are the controls 1 week before diagnosis, controls within 72 hours of diagnosis. Obviously, in the controls, there was no diagnosis of necrotizing enterocolitis, but they're being compared to the diagnosis of necrotizing enterocolitis down here. Here we see that 1 week before the diagnosis, this looks very different than all the others. So there's a difference in the microbial ecology, and there's a shift in the Proteobacteria to Firmicute ratio from here to here. So something is happening that makes us think that there are bacteria, a difference in the bacterial ecology that is involved prior to the diagnosis of necrotizing enterocolitis. When you go much further, doing much deeper sequencing, that's what's seen on this slide. And this is what's called a heat map. And these are just certain regions of this heat map. Each one of these rows is a case. Each one of these columns is a microbial operational taxonomic unit. That would be similar to like a species. And here we see 1 week before, there's no difference in this particular region. And then within 72 hours of diagnosis, we see a lot of microbes popping up here. This is before we diagnose the disease, okay, within 72 hours of diagnosis. This is before these babies are on antibiotics for necrotizing enterocolitis. Some of these bacteria that we are seeing here in the cases compared to the controls are microbes that don't even have a name yet. If you put their microbial sequence, their DNA sequence, into a computer database, you find that they are closely related to certain microbes, for example, Klebsiella. But they are not microbes that we already have a name for. So it's very interesting, and I think that we need to continue in this line of research. I know Cami is doing some of this work at her institution. There are several other places that are looking at this, and I think that there's going to be some answers for this disease coming out of this. But one of the things that we should remember, at least right now, is that diversity in the gastrointestinal tract seems to be a good thing if you get rid of some of this diversity by the use of antibiotics. You may actually cause some problems like altered toll-like receptor signaling and immune dysregulation, and could that actually lead to necrotizing enterocolitis? Very possibly. So let's get back to the biomarkers, and could we be using some of these intestinal microbiota as biomarkers? Well, I think it may be possible, and it may be that we might be able to find the helicobacteria of necrotizing enterocolitis, as was found for ulcer disease. We do know that, 25 years ago, that this bacteria for ulcer disease was found, Helicobacter pylori. Is there a similar microbe that we can find for necrotizing enterocolitis? Possibly. I kind of doubt it. I think it's going to be a whole constellation of things rather than just a single microbe, probably a constellation of microbes added to many other factors, as Cami was talking about before. And if there is such a thing, we're going to need a very sensitive technique to rapidly evaluate the microbe, because you can't do this kind of thing with trying to diagnose this at a bedside. We will have to find something very sensitive and specific for that microbe. And babies will have to provide the samples when needed. Okay, in other words, babies don't stool at will. Okay, so that's a problem. Okay, so let's get into some of the other biomarkers. Let's talk about diagnostic biomarkers for necrotizing enterocolitis. Here, I show you this picture again. Pneumatosis intestinalis, portal venous gas, a definite sign of necrotizing enterocolitis. Okay? Here we have, again, a definite sign of necrotizing enterocolitis. Free air, portal venous gas. Okay? Clear. Those babies have necrotizing enterocolitis. There are some techniques that people are using as biomarkers, such as ultrasound and bedside ultrasound. There are few clinicians that feel that they can really diagnose pneumatosis intestinalis using ultrasound. This is something that has not yet gotten into the mainstream of neonatology, but there are some neonatologists that feel that they are very good at finding pneumatosis by ultrasound that they are not able to find by X-ray. Okay, is there something wrong with the bowel in these babies? There's something wrong with the bowel in these babies, but we don't know what is, we can't say what is wrong. We don't see pneumatosis intestinalis. Here we see a lot of opacity. This might be fluid outside the bowel. Here's a lot of distension, but there's no pneumatosis intestinalis, and there's no portal venous gas here. Is this necrotizing enterocolitis? We can't say whether this is necrotizing enterocolitis or not. So we need to have something that will help us. Okay, so we do have some tools that neonatologists have been using. Platelets, C-reactive protein, white blood cells. These are some of the tools that have been used. And I refer you to this article from the Netherlands that looks at platelet counts, C-reactive protein, and white blood cells. Here's necrotizing enterocolitis. Here's no necrotizing enterocolitis. Seems to be a little trend toward lower platelets and no necrotizing enterocolitis here, but statistically not significant. C-reactive protein, not statistically significant. White blood cell count, it is statistically significant, lower in necrotizing enterocolitis. However, is this specific for necrotizing enterocolitis? No, we see the same thing in sepsis. So this is not a specific biomarker for necrotizing enterocolitis. It may be helpful for us to get a feel for severity of what's going on, but it is not a specific biomarker for necrotizing enterocolitis. So in this article, they talk about some other biomarkers, and I think that some work is being done on these biomarkers here in Athens, and I think that this is really interesting. These are very interesting areas. One is calprotectin, and this is a protein that is found in white blood cells, in neutrophils in white blood cells. And it's resistant to enzymatic degradation, and it can be easily measured in the feces. Maria, I know you're also working in this area. It's elevated in Crohn's disease, ulcerative colitis, but not irritable bowel disease. And here we see in their study calprotectin. This is sorry about the blurry here, but this is no necrotizing enterocolitis. This is necrotizing enterocolitis. Higher in necrotizing enterocolitis. Okay, interesting finding. Claudin, another biomarker. Where do you find claudin? Claudin is one of about 21 proteins that are found in intestinal epithelial cell tight junctions. Here you see this tight junction blown up in a cartoon. Here we see some of the other proteins, occludin, claudin, junctional adherens molecule, and this is some of the cytoplasmic proteins that these are attached to. And these are proteins that help open and close epithelial cells. Claudin is released by the intestinal epithelium when there is a breakdown of the intestinal surface barrier. Claudin is water-soluble, and therefore you can find it in the urine. Here is necrotizing enterocolitis. Here is no necrotizing enterocolitis. Here is claudin, higher claudin with necrotizing enterocolitis. Intestinal fatty acid binding protein, IFAB, mentioned yesterday. Also, small water-soluble protein, which is found in the enterocyte, and it's released into the circulation when the cell membrane integrity is compromised, and it can also be measured in the urine. Necrotizing enterocolitis, no necrotizing enterocolitis. Much higher in necrotizing enterocolitis. So here we see these three together. Here is the this is the IFAB, this is the claudin, this is the calprotectin. All three of these look pretty good. Well, this group actually did some further studies looking at their sensitivity, specificity, their area under the curve, various factors that are associated with the goodness of a test, how good a test is. And here we see that fairly good sensitivity, specificity, area under the curve for all of these molecules. They all look pretty good. I think that this one here, if I was to pick one, I would probably pick this one here as being the best, looking at all of these factors. The calprotectin also looks pretty good, but one of the concerns that I have with calprotectin is the same concern that I have with getting stool samples, is that the babies do not poop at will, okay? And so you have to find a way to be able to measure the calprotectin or to be able to get a sample, because sometimes the babies will not stool for 2, 3, 4 days, okay? So that is one of the drawbacks of the calprotectin. So these predictive biomarkers are, those were diagnostic biomarkers that I was just talking about. They will help us diagnose the disease. But now I want to talk about predictive biomarkers. Who is at the greatest risk? That's what predictive biomarkers will help us. The ideal is to have a non-invasive test where we don't have to take any blood from a baby, not stick the baby, not cause any pain, and right after birth, be able to do a test at the bedside that will tell us that this baby is at very high risk or at very low risk for the development of necrotizing enterocolitis. That is the ideal. Okay, so one test that's been looked at, and these studies are now close to 20 years old, is breath hydrogen. The principle of breath hydrogen is that you take in a substrate, usually a carbohydrate, and that undergoes metabolism in the bowel, and with that metabolism you have CO2 production and H2 production, and you can measure hydrogen and CO2 in the breath. Okay? The more unhydrolyzed carbohydrate, the more CO2 or H2 is present in the breath. So that was actually thought about 15, 20 years ago. The positive aspect of this would be that it would be non-invasive. You might see significantly higher excretion in necrotizing enterocolitis, and the studies that looked at this did suggest higher excretion in some of the babies with necrotizing enterocolitis. But there are a lot of technical difficulties involved with this. And you have to have special equipment to do this. It's very, very difficult to do this technique. And it also depends on what the baby is eating, how much the carbohydrate the baby is taking in. If the baby is getting antibiotics, which wipes out the microbial colonization of the gastrointestinal tract. So this is a technique that never really took hold. Near-infrared spectroscopy, looking at blood flow in the microvasculature, not in the big blood vessels, but in the microvasculature, is something that people have been very interested in. And this looks at the perfusion of an organ. And this is now being used in many of our babies for cerebral perfusion. In fact, we have several apparatuses in our neonatal intensive care unit to look at cerebral perfusion. A couple of studies have applied this to the gastrointestinal tract, have not found it to be useful in the prediction of necrotizing enterocolitis.
On the bowel?
On the abdomen, yes. So one other way is to see if we can develop a predictive biomarker using some samples from the babies. Now, this is not a premature baby, but I just found this for illustrative purposes, and I don't have a good picture of one of our babies that we are doing this with. But you can take a little bit of sample scraping of the cheek and of the tongue, and you can get proteins from the babies by doing this. You can also use urine as one sample source. Other people are using blood as sample sources. This is from Stanford University, and they're using urine to look for predictive biomarkers. And here's a technique that they are using. They're using mass spectrometry profiling. They're taking babies with the disease and no disease, and they're trying to find differences using these bioinformatic techniques. This is the first phase of proteomics, discovery phase, okay? And then once you've discovered some proteins that are really different, you try to validate that using simpler techniques. This is something you could never consider doing at the bedside. It costs thousands and thousands of dollars to do this part of it. But once you find some proteins that are different in necrotizing enterocolitis babies versus controls, you then find a much simpler test. For example, an ELISA test that could potentially be used at the bedside, okay? we're doing something very similar to that with our buccal scrapings. And the way this is done is we collect our buccal scrapings and do protein separation with two-dimensional gel electrophoresis, and then we identify proteins by mass spec, and we confirm proteins, and then we go to the discovery phase, and the laboratory, we hope to somewhere go to the laboratory and therapy phase. But right now we are in this area here. We've recently submitted a paper to the Journal of Pediatrics. I have not received the results yet, but we've identified 37 proteins, and 20 have been mapped with the use of the mass spectroscopy. And let me just show you, these are some of the proteins, okay? Just show you the proteins. These are proteins, okay? That's all you need to see. These are some of the proteins. And then you can actually do something called a systems biology approach. You can plug some of these proteins into a computer, some of these findings directly into a computer, and you can come up with these beautiful systems biology pathways and see what the differences are in the control versus the diseased babies, okay? And we see that some of these proteins are very different in the inflammatory pathway. We picked out some of the proteins for further validation, and 3 of the proteins that we picked out are seen here. Alpha-1 antitrypsin, IL-1 receptor antagonist, and relative peroxyreduxin. And we did Western blots on these 3 proteins. Western blot is just looking at the amount of protein that's present. Much simpler technique. We're not able to see a real difference here statistically because it's a small number of babies. Not able to see a difference here. But this IL-1RA, with a small number of babies, we see a difference. This is IL-1 receptor antagonist. The necrotizing enterocolitis babies, before the development of the disease, had lower IL-1 receptor antagonist. Why is this important? Well, IL-1 receptor antagonist has been seen in studies in piglets to be very low prior to the development of necrotizing enterocolitis. In cell culture studies, IL-1RA, if you take IL-1 with IL-1RA deficient situation, you have increased breakdown of the intestinal membranes, where you have a leakier gastrointestinal tract. So it seems to make sense that this might be a very good candidate. So that's one of the directions that we're going right now. So I'd like to stop there with some take-home messages. NEC is more than one disease. I think if we are to develop a therapy for a disease, we have to focus on one form of necrotizing enterocolitis. And I think that at least for our purposes right now, we are focusing on the classic form of necrotizing enterocolitis that we see in the preterm babies. Most of the current diagnostic markers remain non-sensitive and non-specific, but some, such as the IFAB, calprotectin, claudin-3, may become useful. We need new technologies for early detection, and there are some technologies available to help us develop these biomarkers in the future. Thank you for your attention.
Thank you very much for this excellent lecture, as always.
Very welcome.
I would like to tell you about what you mentioned about these biomarkers. And I want the assistance of the 2 girls that I have, that we work together, because you said that the babies are not stooling very often, although I thought once that we can take a swab from the rectal and proceed with cultures or whatever from there. But even that did not help us to find when we had this necrotizing enterocolitis or neck-like situations. But then, because I had heard another lecture of yours before, some years ago, and we thought that if we take blood from babies and look in the serum, this kind of proteins like calprotectin or IFAB,
Yeah.
because we suspected that then the intestine is leaking and it might come to the blood. So we could find something in the blood, yeah? So we took IUGR babies who were below the third customized centile IUGR babies, and we had also controls which were appropriate for gestational age babies, and we looked for calprotectin and IFAB in the serum. We didn't do Claudin 3, and we didn't find any difference. We did that in order to form a protocol for these babies who would be IUGR, in order, because we wanted to see how we should feed these babies, if we were allowed to feed them exclusively by full-strength formula in cases that their mother did not have breast milk, because if the mother had breast milk, they would receive breast milk. And we didn't find any difference. Could you help us in this way, if we could find some biomarkers?
I think that this is a very difficult situation, and the studies that were done in the Netherlands, I think that they raised some very interesting points, but they really didn't have that many babies in the study. And in order to do this kind of a study, you need a large number of babies. If you're really looking at necrotizing enterocolitis, and if you're trying to validate diagnostic biomarkers, you have to have a large number. And I think what you're trying to do is focus on a specific subset of babies, which is the IUGR baby, which seems to be at higher risk for what you're calling necrotizing enterocolitis. And I don't know if those babies have the classic form of necrotizing enterocolitis. Again, so this is a little bit of a concern if these babies actually are getting the classic form of NEC. If you use a surrogate marker, and I think that one of the surrogate markers you were talking about yesterday was intestinal blood flow using Doppler. And I think that we have to think very strongly, very seriously about whether that is a reasonable surrogate marker for necrotizing enterocolitis. It could be a surrogate marker for lower intestinal blood flow that could lead to ischemic bowel. But is that necrotizing enterocolitis? I don't think so. So exactly how to help you, I think we'd have to do a lot of thinking, and I'm more than happy to continue to discuss it with you and look at some of the details, but I don't think I can give you the answer right at this very moment.
And if I may say another case report, that it is actually very didactic. We had a baby that was full term, and I can't remember if it was a girl or a boy, and it was born by cesarean section for a reason that maybe it was a previous cesarean section. It was elective, I think it was elective cesarean section. And 12 hours after the birth, this baby got very ill and had radiological findings of neck. He or she had received one or maybe two, or maybe possibly not even two, feeds of milk, yeah? And this baby was actually had no problem with cardiac, no cardiac problem, and was operated on 14 hours, yeah, of birth. So it was not a perforation, as you said, a single perforation. It had all the radiological findings of neck. It was so early, it was full term, had no cardiac problems.
Yeah.
What would you think? What could it be?
I don't know. It's very possible that that baby may have had a congenital abnormality of the bowel that was not detected. It could have been a viral etiology. I don't know. I have seen cases like that also, and I can only call it idiopathic because we're sort of whatever, that we don't know enough about these diseases that we can, really make a pathophysiologic diagnosis for them. But is that would I put that into a cohort of the classic form of necrotizing enterocolitis? Absolutely not. That is not. Yeah, yeah, yeah. But I would not put that into the same category as the classic form of necrotizing enterocolitis that I think we need to narrow down right now to those babies that are premature, that are not, that do not have the that do not have isolated intestinal perforations, that do not have heart disease, and I think that we need to stay away from the term babies.
The pathologist gave us the report, neck.
Yeah, yeah, yeah. Pathologists can give it any kind of a report. That's in the past. That's the point. In the past, that so many entities have been called necrotizing enterocolitis, and you can call it necrotizing enterocolitis, but I think what we're trying to do is differentiate some of these entities that we are calling necrotizing enterocolitis into something that is more classic and try to separate them into different categories so that we can actually discover what is the cause of them and how we can intervene with them. Is that?
Thank you for your excellent lecture. I would like to answer to this case. I think most of the full-term babies who get necrotizing enterocolitis have ischemia of the bowel. That's probably basic. And the second thing is how much milk we give. And we should give, of course, breast milk, which is the best. But if you give a lot of formula, like 40 or 50 ml as a first meal, then probably is going to, in an ischemic bowel, probably is going. But anyway, this is something that I don't know really. The point I would like to make, because you said about biomarkers like CRP and the platelets and all these things, I think it's to follow the values, the trend, rather than one value. I think that's the most important thing, especially the platelets. And we had cases, we had actually a case in which we follow the platelets and then we operate the baby, and the baby, didn't have full developed neck, but actually had a necrosis of the bowel. So we should follow CRP and platelets and leukocytes, especially neutrophils. And I think probably, this is not 100% way to decide about how to operate the baby, but
that is very commonly done. That the platelet count, the CRP, neutrophil count is followed for progression or worsening of the disease. Acidosis is another thing that's followed for progression, worsening of the disease. Let's go this way.
Actually, it's a question for Dr. Papagaroufalis and for you too. But do you operate on an NEC without perforation? Because you said it was an engorged bowel. It is not the practice that we use in the EHEA group, because we try to put the babies in NPO, give antibiotics, and actually transfuse them with fresh frozen plasma, which seems that helps the babies a lot. And we try to make them stable, and usually we don't have perforations.
Yeah, and I think that the point there is that there are some babies who have some radiologic, non-specific radiologic signs. Like I showed you, those two babies, they both had very necrotic bowel. Okay, they ended up having very necrotic bowel. But you can't see in some of these babies pneumatosis intestinalis or perforation, okay? And so if you see at least many surgeons use this as a criteria. If they see fixed dilated loop of bowel with a baby who's getting sicker and sicker, and you start seeing a decreasing platelet count, decreasing white blood cell count, more acidosis, I think many surgeons will go ahead and use that as a criteria to operate.
Thank you very much. Sometimes in our NICU, we have intestinal pneumatosis in X-ray without abdominal distension. Only blood in stools or residuals. What you think about this situation?
Okay. The comment was that sometimes they see pneumatosis intestinalis without blood in the stool, without abdominal distension. My question is, why did you get the X-ray in the first place? Okay, gastric residuals. Okay, okay, yeah. Okay, okay. So sometimes a little bit of blood in the stool, sometimes feeding intolerance with increased gastric residuals. Yeah, that's, I think that many of us get X-rays on that basis, and I think sometimes we find babies in the very early stages of the development of necrotizing enterocolitis that have pneumatosis intestinalis. So it could be, very early in the stage of development of the disease, or I can say that in my own experience, 30 years of being in neonatology, that pneumatosis intestinalis is not always that easy to diagnose. Okay, sometimes you see a little bubbly area in the bowel that could represent stool versus representing intramural gas. So it's not necessarily that easy to diagnose. So some of those cases may be truly early neck, and some of them may be just a situation where you're seeing gas in the stool.
Hello. Thank you very much for your nice and new information regarding the biomarkers. I would like to ask you, I saw something in the program, neck and feeding intolerance. What is your experience? Thank you.
Okay. I'm glad you brought that up because I did not talk about it to any extent in this lecture. But as far as the feeding intolerance is concerned, you see gastric residuals and the relationship of gastric residuals to the development of neck. There have been a couple of studies that have looked at that, and the relationship is actually quite weak. If you see gastric residuals increasing markedly over a short period of time, that can make one suspicious, but whether that's diagnostic for the onset of necrotizing enterocolitis, no. So I think that using gastric residuals and feeding intolerance as a marker of necrotizing enterocolitis is not a very good way to do this. Now, let me just backtrack here a little bit, and I think that feeding intolerance is one of the entities that is a scourge of neonatology. Okay, we have so many babies that are having trouble with feeding intolerance, and we don't know how to progress these babies. You have this little 600, 700 gram premature baby, and we don't have good ways to determine how ready they are for advancing feedings. And I think we need to develop some better technologies, whether they be NIRS, whether they be acoustic measurements, whether they be volumetric studies to look at stomach filling and stomach emptying and motility in these babies. We need to have better tools to be able to actually diagnose readiness to feed in these babies. We don't have those right now. What we have is gastric residuals, and as I mentioned before, I think most of us are not very happy with the use of gastric residuals.
For the case from Professor Malamici, could it be this case a rapid progress of protein food intolerance?
It could be. It could be. I think that some of these cases that you were talking about in the two hospitals here, I guess you've had many cases of something that appeared to be necrotizing enterocolitis, sometimes with bloody stools, babies that did not have, most of the babies did not have pneumatosis from what I understand, and most of the babies were late preterm, or term. I think that protein intolerance is one of the things that I would certainly entertain as a possible diagnosis in those kids.
And the second question, could in the maternity rooms may take first a history from the family, and it is, and after give the proper milk, or first breast milk, and if they cannot, the mother can't breastfeed the infant, an hydrolyze or formula.
So I'm not sure I totally understand here. So if you have a situation where you take a history and if you get a history of severe atopic
Milk
disease
allergies,
and milk allergy, yeah, I think that's a reasonable approach if the baby is not tolerating the breast milk. I think it's reasonable. How strongly evidence-based it is, I think that there's still a lot of discussion and some papers that seem to show that it's helpful to use the hydrolyzed formula, some papers that show that it's not. So I think that there's still some controversy about that.
But if there is no mother milk, or the mother does not want to breastfeed,
yes. So
what
the
would
question
you
is
give?
whether you use a whole cow's milk formula versus
Or
a
a
hydrolyzed.
hydrolyzed.
Okay, I think you could go either way. Because I don't think we have enough evidence to support one way or the other.
But since then, we use only the hydrolyzed.
Well, you know,
and we have no
I'm
cases.
not saying that this is the right way or the wrong way. You can't base your entire routine treatment on one case. Okay? I don't think that that's the right thing to do, to base the whole routine treatment on one case.
Thank you, Professor Nu, for your excellent talk again. I would like to ask your opinion. Should we try to start using these diagnostic biomarkers, at least the three ones, the most important, or even the only one in diagnosing NEC, how expensive they are? How can we put them into regular practice?
I don't think they're ready yet. I don't think that they're ready yet. I would like to see some more studies. Most of the studies come from the one group. There's a group in Turkey that has reported a study on some of these biomarkers from the blood. It's, again, not from a very large group of babies, but again, supportive of IFAB, intestinal fatty acid binding protein. Not measuring it in the urine as the Netherlands group did, but in the blood. But I think we're getting closer, and I'm getting more and more excited about using those as a biomarker clinically, but I would like to see more work.
Is feeding a baby with nasogastric tube increase the incidence of NEC?
Does feeding with a nasogastric tube
yeah.
increase the incidence of necrotizing enterocolitis? Feeding with a nasogastric tube compared to feeding with what? For a bottle? Well, if a baby can feed by bottle, then the baby shouldn't be fed by a nasogastric tube.
No, okay. I mean, if you are we are overusing the nasogastric tube sometimes because he's having apnea, or he's receiving some oxygen, or he might be tired. So we say, okay, give the milk by nasogastric tube. We use it as simple as that sometimes. So
yeah,
when you have to choose which way.
Yeah, I think your point is a very good one, and that is that the nasogastric tube can actually become colonized with microbes, and can that nasogastric tube actually increase necrotizing enterocolitis? I don't know the answer, but I think from a theoretical perspective, if you have something that is foreign in the gastrointestinal tract, that is not something that that is something that could potentially introduce certain microorganisms that would not normally be there. So I would be concerned about it, but is there evidence? No, not that I'm aware of. Cami, do you have any additions to make to this? Any thoughts that? Okay.
It was just a comment to the gastric tubes. Last year in Denmark, there was a big discussion about phthalates, the softeners you use for plastic. And we changed to some different tubes without the phthalates in them, and they were a bit harder. And we had 3 different cases of ventricular perforations. We don't know if it was the tubes, but we changed to some other tubes, and it disappeared again. But we are still investigating
You
the
mean
3
gastric
cases.
perforations?
Yeah.
Gastric, yeah. Okay.
Yeah, sorry.
Yeah, yeah.
Yeah. So.
Yeah, I think that that's a really interesting point, is that many years ago, I think around the time when I was a resident, which was around the time that Dr. Hay was a resident, but Dr. Bell was even before. Sorry. Yeah, some of the tubes that were being used that were kept in the stomach for periods of time, for more than 24 hours, actually turned into very stiff tubes, almost like little harpoons, and they saw a lot of gastric perforations. And then as soon as the material was changed to something much softer, then that phenomena almost went away completely. Still occasionally saw it, but very, very low incidence after changing the material of the tubes. But it's interesting that they came back, and somebody didn't read the literature from 30 years ago. Yeah, interesting. Yes.
Do you change the gastric tubes?
I think our nurses usually change them every couple of days, every 48 hours or so.
48
yeah.
hours.
Yeah.
Okay, thank you.
Would you suggest IFAB measurement in serum or urine? Do you think they are equally reliable?
So the question is whether the IFAB measurements are equally reliable in the serum or in the urine. Mm-hmm. And I don't know the answer to that, but the studies that I have seen seem to suggest that they're very useful either from the serum or from the urine. The good thing with the serum is that that's pretty much at your control. The urine, not so much at your control, but certainly less invasive. So from the standpoint of invasiveness, I think urine would be the better way to go.